do we know about the healing of a socket after an extraction? Well, we have some masterpiece papers like the one from Carderopoli and Araujo that explains very well all the healing process. That's a well-structured process that it consists in 3 overlapping phases. The first phase, that's called inflammatory phase, when the socket is filled by the blood clot, and we have the formation between the first and third day of a perfect formed granulation tissue. Then, in the proliferative phase, we have the formation of a provisional matrix and also the formation of the woven bone. The woven bone is a kind of bone that has a node load bearing capacity. And then in the last phase, we have the modeling and remodeling of the bone. It means that by the action of the osteoclast and the fibroblasts, we have the destruction of the old bone and the formation of the new bone. But what the authors pointed out in those papers is a really interesting thing, that both palatal and labial plate suffer a change in dimension, in horizontal way and both in terms of weight. And the most interesting thing, if you follow this line, it's drew following the palate plate, and then we have another line, the yellow line, that's following the remodeling of the buccal plate. As you can see, we have a red line that's quite stable during the healing process, but the yellow one is going down, down, and down. So what does it mean? It means that the buccal plate is suffering more retraction, more resorption in comparison to the palatal one. But why this occurs? Well, it all depends on the resorption of the inner portion of the socket that's called bundle bone. That's very tiny, and when extracting the tooth and losing our periodontal ligament, we are losing blood supply to this part of the bone, and since it's very tiny, it starts lose volume, first in terms of weight and then in terms of horizontal pattern. So the next question is if an immediate implant by itself could prevent or modify this resorption. Well, the answers again from Araujo is that from an histological study, where we can see on the left side an healed socket after an extraction and an immediate implant after its healing. And well, basically, an immediate implant cannot prevent by itself this resorption. Again, and also we have a research study from Vignoletti in Madrid that also explains very well that an healed socket and an immediate implant socket are basically it's suffering the same remodeling process. So an immediate implant just by itself cannot prevent the resorption of the bone. So when we are facing a case of an immediate implant into an aesthetic area, we have to start our diagnostic from a surface and then go a little deeper. What I mean by starting from the surface is that we have to analyze before the smile line of the patient. So first I want to analyze it and understand if it's a normal line, smile line. That's a gift because it will help to hide any kind of imperfection that may occur about the soft tissues, or a gummy smile, eye smile line that's, well, it's hard to manage because you will have to treat perfectly all your soft tissues because the patient won't help you to hide any kind of imperfection that may occur in these challenging cases. Then, going a little deeper, we have to take a look at all the architecture of the soft tissues, the scallop, the integrity or not of the papilla, and also take a look about the phenotype that could be thick or thin. Obviously, a thick phenotype, it's a better quality in the mean of the thickness, and also take a look about the zenith of the failing tooth in comparison to the contralateral tooth. In this case, we have like a slightly coronal zenith. That's also a gift to us because it will be more easy to treat and more easy to manage it. And finally, the last layer, you have to take a look at the CBCT or any X-ray in order to program to plan our treatment. So when having a case of immediate implant, we should start from analyzing also the bone, the hard tissues. We have a classification from Elian about the kind of socket extraction. We have a type 1, that's when we have perfectly preserved both soft and hard tissue at the same level of the cemento-enamel junction. We have a type 2 where we have perfectly preserved soft tissues, but we are missing partially the buccal plate. And then we have the third type, that's when both soft and hard tissue are partially missing. And so, paying attention to our buccal plate, we have a classification by Kahn about the relationship about roots and the bone plates. We can start talking about a class 1 when the root of the failing tooth is facing against the buccal plate. That's a very favorable case. Then we have a class 2 when the root is located just in the middle between the two plates, and then the third class where the root is facing the palatal plate, and then a class 4 where at least 2/3 of the root of the failing tooth is facing both plates. As dentists, we have to recognize that some easy to treat case like the class 1, some sensitive technique cases like the class 2 and 3, and other cases that are sensitive technique, but also you cannot maybe apply an immediate implant with an immediate restoration due to the need of the bone augmentation or soft tissue augmentation before the implant surgery. So also we have to try to detect any possible descents or fenestration in the buccal plate, and in order to do this we have a classification that ideally describe 3 kind of defect that could be divided into V-shape, U-shape, and W-shape. The V-shape defect is the easy one to treat because the defect is just located into the mid-fascial portion of the buccal plate. While then we have a U-shape, then it's affecting also the mesial or distal aspect of the failing tooth, and then we have a W-shape defect, the worst kind of defect because it's affecting both mesial and distal aspect of the bone of the immediate adjacent teeth. So now let's start to analyze our clinical case of the day. We have a very young female patient. She suffered a trauma when she was a child and received an endodontic treatment in the upper right central incisor. The endodontic treatment was perfectly working for many years, but then started failing. Her general dentist also practiced a endodontic treatment, and due to the decoloration also told her to do a veneer that, well, it's a little bit damaged there. But now her general dentist told her that they are going back to have some problems in the piece, and that there was no hope to save the failing tooth. So he asked us to treat the patient. So we are going to analyze the smile line of the patient. We can see that a slightly gummy smile. Well, it's not the perfect ideal case, but, well, and also because she's very young, so I have to treat all the soft tissue with I have to pay extreme attention to treat the soft tissues. Well, we have perfectly preserved architecture, very good pronounced scallop, perfectly preserved papillas, and about the phenotype, we have a thick phenotype, and about the zenith in comparison to the contralateral, we have a gift from the sky that's a slightly coronally zenith in comparison to the contralateral. So it seems to be easy to manage the zenith, and so the final result of the final restoration. So now we can take a look at the CBCT and panoramic X-ray. In the CBCT we have good residual apical bone. That's the bone we have to drill in order to place and gain the primary stability in order to do the immediate restoration after the implant drill. And we can talk about a class 1. Going back to classification, we are going to talk about a class 1, as we have a buccal plate very tiny, but we have on the palate side we have good bone, but we will have to respect also the nasopalatal nerve in the palatal aspect. So going into we choose to go with the trimodal approach. What does it mean, the trimodal approach? The trimodal approach, it means that we are going to place an immediate implant after the extraction. We are going to have a flapless approach and have an immediate restoration the same day of the surgery. So the first step, and it's the crucial one, we have to take out the tooth. And I don't have to provoke any damage to both soft or hard tissue because I can fail in this step basically. So personally, I don't like the use of elevators because into the proximal space they will always damage soft tissue, the papilla, and provoke retraction of the papilla. And so I use my left fingers with the forceps, I just try to do it very, very slowly. You need to take your time in this step because you have to go very, very slow. If I need 30 minutes, I will just doing the extraction in 30 minutes because I don't want to apply too much force. So with the forceps, slightly mesiodistal rotation movement, very, very quiet, controlling the force against the bony plates. And since you have the tooth out, you have first to debride the granulation tissue and stimulate the bleeding of the socket in order to, let's start the healing of the socket. And then with the probe, I check the integrity of both palatal, interproximal, and buccal plates. Why the buccal plates again, if I have a CBCT? Because in the CBCT, sometimes you cannot have a proper diagnosis about fenestration or the essences that are so tiny sometimes, and so with the probe, you check the integrity and confirm that you can go on with the trimodal approach and you don't need a GBR procedure. So in this case, was all well preserved, the bone, so confirm the diagnosis of a trimodal approach, as I told you. So, why I choose the flapless approach? There's high scientific evidence that demonstrate that the flapless approach, the first benefit that I'm not cutting the blood supply to the buccal plates. So first, I'm reducing the remodeling of the bone. Since I'm not cutting also, I'm not painting a flap, I'm not elevating a flap, I'm reducing the inflammatory phase of the soft tissue, so I'm reaching a less morbidity to the patient and best quality of the immediate per-implant soft tissues. That also will means hard tissue stability since the day zero of the procedure. So always, I will go always flapless if I don't need any kind of GBR. So then the next step is start drilling the bone. You have three-pillar concept that we must respect in order to drill our alveolus. First, we have to respect at least 1.5 millimeters distance to any adjacent roots, and also respect 3 millimeters in cases that we have an implant on the side. Then, from an apicocoronary point of view, the implant neck should be located at least at 2 millimeters, maybe 3 millimeters from the free gingival margin of our future restoration. That's very important. I will explain next why. And from an occlusal point of view, as you can see, you have to respect this line that's between the incisor border of the adjacent teeth, and you have to respect a slightly palatal position of the circumference of your implant, and in order to avoid a contact of the implant surface against the the vestibular, the buccal plate, and in order to have the axis of your implant in the palatal side, because I also always practice with screw retained retention. I don't do cemented retention at crowns. So we have the implant placed on the palatal side, 2-3 millimeters in the apicocoronal point of view in respect to the free gingival margin, and where we are drilling. We're drilling against the palate bone and to the residual marginal apical bone in order to gain our primary stability. I try always to reach about 35 Newton of primary stability, so a perfect range of force in order to do our immediate restoration. Since you have the implant placed, I screw an healing cap in this phase and go to the connective tissue graft. I always practice a connective tissue graft both in thick and also thin phenotype. Why? Because, well, I want to compensate the bone's volume loss, and remember, I just want to compensate. You don't have to over-contour with soft tissue because you will fail in two things. The first things, then you will have an over-contoured Crowne. That's basically a failure from the aesthetic point of view. And also, if you over-contour too much with the soft tissue, you will have a reflection light defect. I mean, if you have two central incisors and one is missing, you have to not over-contour the one is missing tissues because the lights will reflect in a different way in comparison to the natural adjacent teeth. And that's maybe the patient won't appreciate it, but you will see it and you will get mad about it. So in order to gain the proper thickness, I just suggest to take the 1.5 millimeters under the layer of the epithelium in order to get the best quality tissue as possible. That's called the lamina propria. And about the donor site, we have two options: the tuberosity, the retromolar site, or the palate. Nowadays, the tuberosity seems to be the best quality about donor site in order to less morbidity to the patient, and also it's an easier technique with a double incision technique, and so basically we have all advantages. But sometimes you don't have tuberosity, so you have to go to the palate, as we can see in this case. And basically, with the connective tissue graft, we are thickening and stabilizing the soft tissues during the healing, and so we are avoiding any buccal tissue collapse. Do you have any question?
Why don't you use process bone?
Sorry?
Why don't you use
Process bone?
process bone, like cadaver bone or the chemical?
Well, this is a connective tissue. I mean, this is just soft tissue graft.
Oh, I thought you said you were
Okay, but yeah, but well, it's a soft tissue graft, but I don't use also a synthetic tissue graft. I don't like the use of synthetic because during time they are not so stable like the proper natural tissue of like the palate or the tuberosity. In this case, I'm just having a soft tissue graft with no bone. Okay, we are going to see the bone graft too. So we can see the harvesting and suture technique. First, we have to prepare the buccal flap. I mean, it's not a proper flap. You have to tunnel the flap. You can do in a split thickness in thick phenotype, and I suggest in thin phenotype to do it in the full thickness in order to avoid any kind of perforation of the soft tissue that will complicate the treatment. So since you have your tunnel done, you can go to, in this case, I went to the palate and applied a single incision technique. You can see here the single incision, but you can also use a trapdoor technique and also a free gingival graft technique. Nowadays, basically I always do a free gingival graft technique. Why? Because then in my surgical field, out of the mouth, with my magnification, I can remove the epithelium layer and so get perfectly the 1.5 millimeter of the lamina propria tissue, okay? But well, the technique is to each one. The best that is working for you, it will be the best option. So since you have the graft out, you have to present to the receiving zone. You have to check about the dimension in terms of length, thickness, and height. And then you can obviously you can rectify in the before the suture and cut it if needed. Then we'll try to, well, you have to suture it with an horizontal matrix. You check the stability of your connective tissue graft. I practice with one suture stitch, but sometimes I also do with another coronal stitch. It depends on the stability of the connective tissue graft, okay? And then after I have sutured it in the receiving zone, I will go back to the palate and start the suture of the palate. You can do with single stitches, like in this case, or also practice with horizontal matrix or crossed horizontal matrix with dental anchorage. So, since we have the connective tissue done, we have to manage our gap. As I told you before, when drilling the implant, we were trying to gain at least 2 millimeters gap between the vestibular implant surface, this portion of the implant, and the buccal plate. I always try to, I have to avoid the contact of the implant surface against the buccal bone wall because it will produce more resorption. So I want to have a gap at least 2 millimeters, and then I always fill the gap with particulated bone. Okay, that's in this case, I always try to use bovine bone, but I have to ask due to religious reason to the patient if they can receive the bovine bone or not receiving the porcine bone. But I try to explain that I prefer the bovine bone due to a better stability in time, but I have to understand also the patient reason. But in this case was a DBBM bone. So basically I always graft my gap. Then the last step is going with the immediate loading. What do we know about the immediate loading from the last ITI consensus statement is that we need at least a torque value of 20 Newton or an ISQ value of 60 Newton. That if there is no bone defect, we can easily practice it. It doesn't affect the integration, the osseointegration of the implant, and then we are gaining more, we are having more benefits than any, and not, basically no risks. And the most important benefits are the improvement, the enhancement of the quality of the soft tissues, and we are just stabilizing the soft tissue. And since we have stable soft tissue from the day 0 of the surgery, we'll also have hard tissue stability from the day 0. So we are taking the impression, and just few hours after the surgery, we are having a good provisional restoration that should be with less length as the contralateral in order to avoid any contact, occlusal contact. In this case, we have a little diastema. I explain why. Because in the mesodistal aspect, the veneer that she had was bigger than the contralateral. And I also offered the patient to receive a veneer with in order to do the final restoration. And the most important concept, we have an interesting paper from Cabello that well explains the effect of the immediate restoration in comparison to just an healing cap. With an healing cap, all the soft tissue while migrating into the socket. While, due to inhibition by contact with the immediate restoration, we are avoiding the migration into the socket of the soft tissue. So, and this is the concept of the restorative tissue inhibitor capacity of our immediate restoration. And so, you have to have a very well-known concept that are the critical and subcritical contour in order to do a perfect immediate procedure, a loading procedure. And the critical contour basically is the 360-degree surface 1 millimeter range area that's allocated 1 millimeter apically to the free gingival margin, and this is the responsible of the crown length restoration and the responsible also of the aesthetic result of your restoration. And this has to reproduce perfectly the shape of the failed tooth or the contralateral. If you want to produce a slightly coronal movement, you can reduce in the buccal aspect about 0.5 or 1 millimeter compared to the natural tooth. Then we have the running room from the critical contour till the neck of the implant. That's called the subcritical contour. That's the space that has to be as concave as possible in order to give the more space as possible to our regeneration. I mean, soft tissue, the connective tissue graft, stabilizing the blood clot, and also giving the xenograft the space it needs. At the day 0, you have just to do as concave as possible the subcritical contour and the critical contour reproducing the failing teeth. After the healing, about after 3 months, you can modify the critical and subcritical contour in order to reach a perfect aesthetic result. But it will depend on the scenario. Basically, if you have a slightly apical free gingival margin in the buccal aspect, you should reduce the volume in the buccal aspect of the critical contour and enhance the concavity of the subcritical contour to push your tissues down coronally. And then we have a modification done by Ramon Gomez-Meda about the critical and subcritical contour. That's basically, he described the E, B, and C zone. The E zone or aesthetic zone is just the critical contour. And the B zone and the subcritical contour, it just basically split it into two, the subcritical contour, by describing the biological boundary area that is the responsible of the soft tissue quality as concave as possible. And then we have the C zone, that's the crystal stability zone, that will be in contact with the supracrystal connective tissue. So in this zone, the abutment should be as strict as possible or a slightly concave design. So here we have our final restoration and the CBCT. In the final restoration, we can see that we have a bigger mesodistal aspect because finally she didn't want to have the veneer in the 21 piece. A perfect zenith in comparison with the contralateral. So by an aesthetic point of view, we reach a perfect result. The patient is really, really happy. And from a CBCT cut, we can see the perfectly positioned, three-dimensional positioned implant. We gain some thickness with the xenograft, and we reach to compensate the volume loss due to the socket healing. So, in resuming, the keys to success in a trimodal approach, first you have to do a proper diagnosis by, as the proverb says, well begun is half done. You have to take time to choose the correct approach. And then, positioning in the three-dimensional point of view, a perfect positioning of the implant. Always practice the combination of the connective tissue gap filling and the immediate loading as always as you can, because you will enhance the quality of your aesthetic result. If the patient doesn't want an immediate loading, you can practice an customized healing cap that will always do the inhibition by contact process.
Here, the diameters are so that way you can identify the size of implant you're going to be placing and take one size before, so you can undersize your osteotomy and then place your implant, right? So for example, if you're going to place a 4.3 millimeter Nobel Biocare implant, your last drill sequence is going to be 3.7. Now, if you have a hard bone, you're going to put a 4.2, not a 3.7, and be able to still engage on your implant, right? So it's only one drill protocol. So what you have in here is the drill itself with different diameter lengths in here. As normal, you will have the 6, 8, 10, 12, 14, 16 millimeters. Ultimately, for this practice, it doesn't matter because you don't have to look into the type of implant you're going to be placing. If you have a type 1 only, you can just elevate your sequence to a different type of drill. Simple process. You punch the gum. Once you punch the gum, you drill a hole. Now, I want you to try different settings, okay? If you were to try in a very low setting, in a regular drill system, the drill that you use in your regular setting is not going to penetrate the cortex of bone. So it's going to be very hard to penetrate that. With these drills, they're called bone blades. With these drills, even at low setting, you will be able to penetrate. You will feel how the drill engages into the bone right away. You could use it as low as 50 RPMs or as high as 2,000 RPMs. The recommended is going to go for it and then use it. So go ahead and try that and see how easy it is to drill through that, to that jaw. And I'm going to just run a small video how this will work, right? So while some of you are drilling, I'm going to show you this video. So in an implant bed preparation, in an easier way, a freehand preparation, you raise your flap, and then for one drill protocol, sometimes if you feel that you want to do a mark, so this is an anterior case. We have a limited amount of bone, but enough to place a narrow diameter implants in positions of the lateral incisors in the mandible. And in an ideal case scenario, you would like to do this guided, right? But in this case, we can use a freehand as well, as you know the parameters for the bone, where the bone is located. When we do this with a full thickness flap elevation and trying to preserve the keratinized mucosa, displacing that keratinized mucosa to the buccal side. And this is not sped up or anything, this is a real time, so that way you can see the time that it takes to do the surgery. So the torque is set up at 35 Newton centimeters. So, and then the placement of your implant in the osteotomy site. Narrow diameter implants. These are Nobel Biocare. Internal connection, conical connection. And torque value.
Okay, in a flapless approach, the only one suture is to the connective tissue graft. In the tunnel flap, the tunnel flap in this case was a split thickness flap. So you have periosteum to the buccal plate and then the superficial layer of our tissue. So in this, there I suture with a horizontal matrix my connective tissues. And just in the internal layer between the surface of the implant and the buccal plate from the internal point of view, then I fill the socket with the xenograft, with particulated bone. So I don't need suture because it's particulated, mix it with maybe, sometimes I mix it with the bone drill, so I mix 50% of xenograft. If I have recollected bone by the drilling, I can use this bone, okay? But if you want to recollect the bone from the drilling, you should slow down your speed of the burst in order to don't burn the proper bone. So in this case, I didn't need the use of a membrane, okay, to protect my xenograft, because there was not dehiscence, there was not fenestration. If you have a fenestration, what you can do is, even with the flapless approach, you will have to tunnel the flap, but not in a split thickness, full thickness, okay? So yes, you are going to detach the periosteum from the bone. I suture as a connective tissue my membrane. So as you have seen the connective tissue, imagine change the soft tissue with a membrane, an ice cream cone technique it's called. Suture it like it was a connective tissue, put the xenograft, and then my connective tissue graft will be different if I practice it. It just will be in the 3 millimeters coronal from the gingival margin, because I don't have the space between xenograft, membrane, and so the connective tissue will just be in the coronal section of our surgery field. Yes, this was a thick phenotype. Sorry? Why? I always practice CTG, because the aim of our CTG is also to compensate the volume of the bone. Because I'm preventing it by using a flapless approach, I'm preventing compensate the resorption by using the xenograft, by using the flapless approach, and with the connective, I will always have reduction in the horizontal mean of the buccal plate. But I can compensate with my 1.5 millimeter of my connective tissue graft. So always you will have to compensate this volume, hard ball volume of the bone loss. So always practice a CTG in order to compensate, as I told you. But don't excess, you don't have to exceed in the thickness, because it will over contour too much. So you will have an over contoured final restoration that's not so aesthetic. And also, as I told you, the reflection of the light is really important from the dentist point of view. The patient won't see it, but you will see it with your photos. And you will check that there's something strange, and you won't be happy. You will get mad. Okay, you're welcome. Very welcome. Any other question? Okay, please. Mm-hmm. Okay. If you mean about the socket shield technique, I don't like it. I don't like it. I don't like, and I don't practice it, because basically there's no eye stability, according to me, during the treatment after years. I had to operate then cases that have failed the portion of the root, of the vestibular root, the buccal root, that got infected many years then after the treatment, and so I have to have a GBR treatment with an immediate place implant, and so personally I don't like the socket shield technique. I prefer to take the entire root out, practice my three-dimensional drilling as I explained, and you won't have problem by using a xenograft. But well, it's about everyone does as they like, but well, I don't like it. Yes, please.
Yes, thank you.
You're welcome.
What do you think about supplementation with vitamin D after immediate implantation?
Mm-hmm. Well, there's some colleagues that use it. Personally, I don't have experience using the implementation of vitamin D in those cases. It's true that there are studies that seem to explain that the vitamin D obviously enhance the bone results, but well, personally, I don't have the experience to say that's not good or not. Some colleagues could explain it better. Sorry.